It's one thing to search the internet for health tips. It's another when misinformation goes viral and ends up in the exam room. Lately, more cancer patients have been asking about using Ivermectin, a drug designed for parasites, as a cancer treatment. So today on Doc Talk, we are going to cut through the noise with an expert who sees these questions firsthand, Dr. Bayan Al-Share from Monument Health Cancer Care Institute. We'll unpack where this idea comes from, what the science really says, and how to separate fact from fiction when your health is on the line. So welcome, Dr. Al-Share, for coming in again. I appreciate it. So good to talk to you again. Yeah, we have other episodes with you, of course, where we've talked quite a lot about what you do. You're an oncologist with Monument Health, and it has to be an interesting time for you right now with what's going on. The whole Ivermectin thing, I believe, goes back to COVID. Is when people first started to use it, correct? Is that when you guys kind of first noticed it in your profession?
Yeah. I think COVID is where things started, where patients had some information about it might be curing COVID faster or protecting you from actually having COVID. So they were taking it as a prophylaxis or a preventative thing. And of course, it always takes longer time to prove or unprove any idea or any suggestion about medication, that if it works or not on certain indications. And lots of clinical trials, lots of also data that followed that. And then we started seeing it more recently in cancer care.
So how did it even end up in this conversation with cancer? How did it jump from that to cancer? Because they're two very different conditions, right?
Yeah. Now, all medications, they are subject to be tested at the lab. In a certain way, it gets to the lab, so it's a medication, it's an available medicine, it's a substance that might be working against different type of diseases. Now, Ivermectin is an anti-parasitic medication, so we use it for treatment of treating humans for worm disease. So it works for certain indications, and it was tried in the lab on some cancer cell lines, we call them, on certain types of cancers also, and it started to show that, it might be killing cancer. Now, that's only in the lab so far, so I think that's where anything that comes published is published out of the lab, it might affect when someone is reading it. And somehow, some results on lab Ivermectin killing cancer, it's got understood probably that, it cures cancer. It kills cancer cells. We probably, whoever started the idea of saying that, let's use it to treat cancer for now, did not think of what type of cancer it might kill. Is it really effective in killing all cancers or any type of cancer? And is it really safe to use it? Mm-hmm. And what happens if it's translated to humans also? Because all of these medications that are proved, and we have millions of medications that are used in labs on cell lines or on certain type of cancer cell lines that might be working, at certain concentrations, high concentrations, maybe low concentrations. It might be killing the cancer cell, preventing it from making its own proteins, from dividing into new cells, different ways. But the idea of becoming a cancer medication is from proving that I can translate this into the human body.
Right. So we always hear these stories. They're all, and I'm interested too in how a lot of this stuff, and maybe this is a silly question, but gets out into the public. When this research is being done, and they're working on mice and things like this, in a lot of instances, I believe. And they're like you said, maybe this might work on this.
Yes.
How does that information get out into the public? I don't know how lab research works, I guess, would be my next question. But it seems like you would want to be like, look, sure it does, but let's just keep this, we don't want this because of the way this can explode.
Yeah.
Right?
And I think we are in the era of having everything published. Everything is out to the public. We don't know when we are publishing, as like let's say there is a scientist who's working in his lab and he really found promising results on certain medication or certain substance that might be working against certain disease in general. He wants to publish his work, and publishing the work has so many pieces that we have to look at to say, is this significant? Is this something that really is promising? What follows to make sure that, we have initial data. What will follow that? I think when it's all published, it depends on the audience and it depends on who reads it. If it's another scientist who knows that this is not going to go directly to a human to use it, that's not ready to go there. And if it's not a scientist or someone who does not carry any degree that has to do with how research goes, might just say, well, I read about this, like it's working, it killed those cells, and then let's try it because it's available. Because there are certain substances probably or medications that they'll read about it, but it's not interesting because we don't know it. It's not a medicine that we have in our hands. So maybe that's what made ivermectin one interesting thing for people. On the other hand is that we know that there is an oncology, let's say, there is modern oncology where we follow evidence. We follow high-level evidence. We need multiple layers to get to believe that a medication is working. But there is, on the other hand, the alternative medicine, where we don't say anything against alternative medications because most of the treatments, they might start actually as alternative medication. Some natural medicine thing like aspirin, it's coming from natural sources. There are some cancer medications are coming from plants. So it starts there, but that doesn't mean that we have to translate this into, let's take it, let's try it. We in oncology, we need first lab evidence that this will work. What are the doses that are working for this? What is the concentration that you need? And then let's go take it three steps at least, where I need to know, is it safe? Is it safe to be given to a human? Is it does it have any effectiveness? Is it really effective? Because when you put in anything in a human body, you have to think of so many factors on how this medication is going to go into the system, how is it going to be metabolized in our body, what's the concentration that's going to be in our blood to give effect, and how much of it is free actually to work, because some of the medications, they're actually binding to our proteins, they're not active. So if I'm giving high concentrations or high doses of medications, it might not give me the efficacy I need because I know it's not actually translating into any effective concentration or dose in the human body. And then if we proved safety, we proved effectiveness as well, then the third layer that's very important in oncology is, well, how does it compare to other medications? We have so many high evidence-based medications that we are using, whether it's chemotherapy, targeted therapy, immunotherapy, and we're still having new medications. How does this compare to other things? The higher level of evidence that we're always looking for is like, I need to compare for things that we are using right now. Compared to the lines of treatment, is that more effective? Is that making patients live longer? Or making patients feel better? Is that like, what am I looking into this medication to just say, okay, well, it might kill cancer cells, but it might kill patient or give toxicity actually. So we have to have this mature thinking of a medication that might work, so we can think of it as, or that it be to be advanced into a cancer treatment.
So when a patient comes into you and starts the conversation of ivermectin, what's your first reaction to that? And then how do you start the conversation of, okay, I hear you,
Yes.
but.
Yes, exactly. I try not to ignore any question my patients ask or any thoughts that they have. I think it's my professional responsibility when my patient asks me a question or tell me that they are using something, whether it has an evidence or it doesn't have an evidence, to give an opinion coming from my knowledge and from my experience and from what I'm licensed for. Mm-hmm. So I never ignore their question, and my patients who are hearing this, they know. I always tell them that we have to know that ivermectin is something that has been promoted for in the community. I hear it over 10 times a day. That's at least 10 times a day, where if my patient says, I want to ask you about something. Can I just ask about something outside of our treatment? I first tell them, can I guess, is it ivermectin? And I think 9 out of 10, it is the right. I'm right, actually. So when my patients ask me this question, I tell them, I know where you're getting from. You're just hearing a lot about it. You're reading so much, but you also have to know where to read and where to get the information from. People tell you, and social media and what's being promoted to the public is that ivermectin works, it kills cancer. This patient was cured of cancer. This patient did not have any cancer. He had a stage 4 cancer, now it's gone. Well, they don't know that there were some incidences where ivermectin was published to in general on if you actually search for this, you would know that there were patients that their disease was gone. They were on ivermectin, and that was published like this. They said, patient used ivermectin for so many months. He had a stage 4 cancer, and his cancer was actually gone with no evidence of disease. The fact that wasn't mentioned, that some of those patients actually were on chemotherapy. Where is the standard of care that we really know that if something is working, it's this one? Mm-hmm. Where did it go from the publication? Because, and you would know that, how do you trust a source that's not giving you the whole story? And if you want to hear from someone, you have to hear from someone who qualifies to tell you this. The most common thing that I hear from my patients is that they don't want this medication to succeed. All the pharma companies don't want this to succeed. You doctors don't want us to use it because it doesn't cure cancer. Well, I'll be the first one thrilled to know and to tell my patients that we have an easy option and we have a safe option, and we got one more option. We have thousands of medications that we are using. Why not to add another one, right? Mm-hmm. So it's not like we have anything against it. I think I will be the happiest when I know I have another option to treat my patients.
I do. I find that, and that's, when this comes up in conversation, you mentioned, people are afraid of big pharma and think that that the cancer cure exists and they're just not letting it out because they want people to be sick forever. But having talked to you over a handful of podcasts that we've done, I can't imagine that you wouldn't want every single one of your patients cured of cancer immediately. Why would you want to keep them on any longer than they have to be on anything? Absolutely. And if this is a drug you could throw out that would work, great. Yeah. But one thing that pops into my mind too, and you mentioned, people that have been on chemotherapy, they get cured, but they were also taking ivermectin. Can it interfere with the other treatments that are happening as well? Have you guys found issues there?
Yeah, and that's very important issue. Is that sometimes patients, they tell me, well, I'm taking your treatment, but it might help. So why won't I stay on ivermectin? Mm-hmm. And I'm always against this because of the knowing that ivermectin, it's not like a harmless thing. This is a medication that has the possible benefits, as there are some claims about in cancer. I don't know. I will never say until I have a proof. But it also has possible toxicities. So that I tell patients, first of all, I know that in ivermectin, and that has been studied. That's also something that's there for the public. If you're doing your research, do also the research on the possible toxicity and adverse reactions to ivermectin, including the possibility of neurotoxicity, which means it might cause something that does problems with your brain, how it functions. The least of it can be a headache. The least of it can be dizziness. But there are patients who get at higher doses. They might get to the level of having tremors, having seizures with ivermectin. There is also the possibility of skin toxicity. Skin rashes might happen. Some changes in your skin that might happen from ivermectin, affecting some of your vital functions like your liver. Now, everyone says, well, at the low doses I'm taking right now, it doesn't affect my liver. Yeah, those low doses, they did not show that it will work. So why are you taking it? Just in case. So, you know that at this low dose you're taking, it's not going to be effective and it's not going to be harmful. So what's the point of taking a medication? Mm-hmm. So it has its toxicity. It has its interaction with our medications also. Now, any medicine, even if I have my patient on ibuprofen or a Tylenol, I have to run an interaction check. Our pharmacy has to go through what we call interaction check for every single medication the patient is taking. And we have drug-drug interaction between very safe medications. We never think about it. And I won't be surprised if ivermectin interacted with lots of our medications. And I tell them, if I have a problem, let's say you are on chemotherapy or immunotherapy, and you are on ivermectin, and I allowed that for a reason, and then a liver toxicity happened, or a skin rash happened, or any of the toxicities, how am I going to evaluate where the toxicity is coming from, and how am I going to treat that? Because if I'm keeping you on the chemotherapy, and this is a possible toxicity also, that's not the right thing to do. If I'm stopping the chemotherapy and you are at home on ivermectin, I won't be able to catch the problem or treat it. So definitely, it's not a harmless thing to use.
It seems like that balance, is as a doctor, oncologist specifically, is super frustrating. Because again, you're trying to be compassionate. You know they're going through a very difficult time in their life. So how do you balance being respectful of a patient's hopes, while still giving them the hard truth? I mean, how do you? You've kind of explained it a little bit, but are there other examples you can give?
Yeah, absolutely. So I can give a couple of examples. So I have patients who come in and they tell me that I want to hear about what you have for a new diagnosis, and I want to know what options I have, but I want to be treated with ivermectin first. I want to give it a try, and I believe that this has good chance to work. And I always tell them, I don't know what you do at home. Mm-hmm. I don't control anything outside of my clinic and our infusion center. Anything that I put in as a treatment plan, I am in full control. Anything outside, I don't know. So if you're going to take ivermectin and take my treatment or not take my treatment, I cannot control this. But if you are planning on taking ivermectin and you know that you're going to do it, I will not recommend putting you on any of my treatments. I do not refuse to be your doctor. I will not stop being your doctor because that's a big responsibility. Right. You have cancer. I can't let you on your own with that. But you want to take a month, you want to take 2 months being monitored and making sure that you don't go in toxicity. And I've had people who went in toxicity, but I won't start chemo or I won't start our standard therapy until you tell me that you are fully committed and you cannot be on ivermectin. Now, there are patients who might go on ivermectin with my treatments. I try to educate as much as I can, and I always tell them that I'm addressing this and I'm taking long time of our appointments just talking about this because I care. Mm-hmm. I care I don't want you to get into a toxicity. I don't want you to be in the hospital from something we don't know how to reverse. And there are patients who actually had harm from those medications. The other important topic with ivermectin is that usually it doesn't come on its own. Usually it's not the only alternative medication that they are taking. Mm-hmm. So there are regimens of alternative medications that come all together as a package. So they usually get ivermectin. It might be with febendazole, which is the dog dewormer, and high-dose turmeric. Lots of treatments that might have evidence later on that it might be treating cancer, whether as a combination or separately, but we don't have enough evidence about it. And the toxicity comes from either of these. Right. And it makes it even harder because you don't know what's the combination that they've been on. But definitely I try not to mix between those. One of the scenarios, one of my stage 4 patients decided to stop treatment. So said, I don't think you have good options for me. I had so much toxicity. And I think that your options are not better than the chances and the odds that ivermectin is going to help. I just have to clarify as much as I can where I come from and where my concern is, and my concern that if your disease is at a point where I cannot help with it anymore, and ivermectin proved that it failed, we might be losing a window to treat. If my patient is understanding risk and benefit, at the end, this is their decision and this is their lives. I tell them, I give you recommendations. I try to care as much as I can and be the one who's supporting you through every single step in your treatment. Mm-hmm. But I cannot take a decision for you. So if you decide to go that route, you should know risk and benefit. I should spend the time with you explaining risk and benefit. And if you tell me this is an informed decision, I know what I'm doing, then that's most of what I can do.
Right. Well, and every time I see stories like this, or I'll see certain doctors on social media too, that kind of share this same frustration. You know, I mean, let's say an ivermectin worked. Let's say a dog dewormer worked, or turmeric worked. You know, if it was studied properly and it shows that it did, you are not going to be all of a sudden saying, well, no, I'm not going to recommend that, because the science is there. Yes. The studies are there. And I think I can understand people's frustration of, I mean, cancer is it's not a quick cure process, if it can be. I mean, it's going to take a while. There's going to be lots of things you recommend, steps they have to take. But I think people want that, what's that medicine that's going to fix me instantly? And with cancer, that doesn't exist mostly right now. And maybe, is that what some of these patients get frustrated with?
Yes. Now, it depends. There are some cancers that really there is a quick fix for those cancers. And we know that our chances of doing a short course of treatment, it also depends on the stage of cancer, the type of cancer. So there are sometimes some curative options. And that's where we hate to see a patient declining this medication or this type of therapy because they want to try something else, because we know the chances of them actually benefiting with a high level evidence that, yes, well, I already know this regimen is going to, it has high chance to help you. Why do I leave this one to the unknown? Right? So even if this might be helping, but I know this is proof that it helps. So just try the thing that has the evidence. So patient's frustration comes from that I want a quick fix for that, and ivermectin is not going to be a quick fix. Plus, people who recommend it to them and people in the community who just say, well, I've been on it for 5 years. They don't even have cancer. They're taking it because it might kill cancer cells, but they didn't go through cancer. So why would you try something that non-cancer patient is trying and he didn't get cancer? Maybe because he was never going to get cancer.
Right.
to start with. And then another, coming to facts and to science, we know that ivermectin is being studied. we're not denying this fact. We're not denying the fact that it might actually become part of cancer medications. Whether at that time we'll be here or it's like someone else will be treating cancer, I don't know. Might be. I might catch this. But it's in clinical trials. So far, there are certain cancer cell lines that it worked on it and certain cancer cell lines that are resistant. So don't think of cancer as one entity. Cancer is so many entities. It's not just one diagnosis. It's not like when you just say that this is I don't know, even flu is not actually one entity. It has
right.
tons of entities. But it's not like one certain diagnosis that you say, that's the disease, that's how it's going to be cured, or that's how it's going to be fixed. Cancer is depending on so many genetic mutations, so many other factors in the body, so many factors in the person themselves that makes it special in every single case. It's not going to be treated. Cancer cell lines, prostate cancer is different from breast cancer. It's different from pancreatic cancer. It's hard to think of it as all as one entity and one medication at one certain dose is going to cure it all.
Right. Well, you mentioned the clinical trials, and just because something is in a clinical trial, there is no guarantee that that is going to end up working at all for anything. But I think people see, clinical trial, ivermectin.
Yes.
Must be because they found something. And like you said, maybe.
Yeah.
But that doesn't mean you go buy as much of it as you can and start taking it.
Yes.
Because it has to go through that process that all of these other wonderful drugs have gone through that are helping people get through their cancer journey for sure.
Yeah. And when you say clinical trial, who's doing this clinical trial and how regulated is this clinical trial? There are clinical trials that are regulated and they are well designed. Mm-hmm. So you would trust that, yes, I would trust it's designed in the right way, and that's for experts. Even me as an oncologist, I'm not the best one to judge a clinical trial if it's well designed or not, but it has to be a high-level evidence, because if someone says, it's in clinical trials, the trial doesn't mean just a series of cases that were reported, peer-to-peer review, or someone just read a few cases, they said, well, in my clinic, I treated with this medication, and that's what happened. My patient had a headache one day, but this patient did not have anything, and this patient, his cancer is gone. That's not a clinical trial. Clinical trial is a very regulated thing, and it's very strict monitoring for every single thing and strict reporting to toxicities, to efficacy, and to know how to report that. Is the disease cured? Is the disease responding partially? Is the disease stable? Is the disease actually refractory to treatment? So there are so many things to say that this clinical trial is actually a clinical trial to trust. If you go to clinicaltrial.gov, where all the clinical trials in the world are actually registered to look at cancer treatments or other treatments, even not only cancer treatments, but this is a trusted source that look and see how many clinical trials on ivermectin are now. And this morning, I just wanted to go in and see there is only one clinical trial on ivermectin in cancer that is now active, and it's recruiting. It's a phase 1, phase 2, testing the safety and effectiveness of ivermectin with one of the immunotherapies for only one type of cancer, which is the advanced triple-negative breast cancer, we call it, which is one of the harder to treat breast cancers, and in patients who failed multiple lines of treatment, at least 2 lines of treatment or 2 options of treatment. So it's not like for all cancers, and it's not in the first line. It's not comparing to anything. We're testing safety still.
Right.
And I hope that looking for clinical trials, look for a trusted source to see when you ask about it, or when you say, I believe that there was something reported.
Well, speaking of that, if someone wants to dig into trustworthy science-backed information, where where should, in your opinion, they start looking for this?
So there are lots of sources that you can easily find. First, clinicaltrial.gov is a place where you can just list your type of cancer and look for, and maybe list the medication that you want to know if there are any clinical trials on it. And it's open for the public. You can easily just go there and search, and then it'll tell you over the world, what are the registered clinical trials? Are they recruiting? Are they terminated? Because some clinical trials, they actually terminate early because of possible harm, if we don't use this medication, it proved it's so good. So that will be reported. If it's resulted and its results, that will be there. So it's an easy access for what has been going on, and what we also look at when we're looking for clinical trials to report to our patients, or to actually enroll our patients. If you want to search on Google, usually Google is not everything on just general search in Google, you will have the right information. There is Google Scholar, where you find all the publications from researchers in a very organized way, and it's always in good sources and from good papers and articles that are publishing there for the public. So you can search those good ones, not TikTok.
That was going to be my next question. So where on TikTok do I find the information? Probably nowhere.
if my patients want me to take my evidence from TikTok, they can search TikTok.
Well, Dr. Al-Share, it's always great to talk with you about this. I appreciate you so much coming in, and I know this is something you're pretty passionate about. So I'm glad we got a chance to get this podcast done and get it out so people can hear it. Is there anything else I missed? Anything else you wanted to cover?
No.
Okay.
I think I just want to tell our patients that we will really be thrilled if we know that any of these alternative medications will work. But I hope that they will trust that we want the best for them. And when we are against anything, it's not because we don't want them to cure their cancer. That's why we are there. We want you to either cure or control your cancer. Yeah. So I hope you'll get the information from the right source.
Excellent. Thank you very much. Dr. Al-Share is an oncologist with Monument Health here in Rapid City. Thank you very much for listening, and thanks for coming in, Doctor.
Thank you for having me.